Question is, what is a chaperone therapy?
Chaperone therapy is something which is currently in development. It's a method where you try and help the enzyme go from where it is to enter inside the lysosome. So it's chaperoning the enzyme which is misfolded or not appropriate and is not reaching the enzyme, not reaching the lysosome where it's supposed to be.
Okay. Is that in some way connected to that information you were talking about with the CRIM titer, how some of them create more of the antibody? Is that to help subtrovert the production of that antibody titer?
No, I think those are two different issues. Yes, yes.
Okay, yes, please.
Question for Dr. Krishnani. Thanks. I enjoyed your presentation. Thank you. You raised a lot of issues, though, kind of what's out there. I guess my question is, how do you go about scientists in general in terms of prioritizing what you work on, and if so, what are the priorities kind of going forward?
I know.
Yeah, get close.
Yeah. Some of the priorities really are based on commitments that have come from both the EMEA and the FDA. Although Pompe was approved for broad label use, that is for both children as well as the adults, there's a lot of work that is still needed. That both agencies have requested and have required. One is, the completion of the information of the trials for the late onset patients to show benefit, and this is one study which is ongoing right now. It's a double-blind study. Another, I think, is on issues related to how the surviving patients are doing. And so I think these are immediate priorities, but I think there are other priorities such as improved targeting to the muscles so that patients can actually have a better response. I think a second very important thing is a quick diagnosis so that early treatment can be initiated both for infantile as well as for the adults. And with respect to that, now there's availability to do this on either blood in white blood cells or in dried blood spot, what is used for newborn screening. I think another real important target is newborn screening, so you can really pick up early and start treatment early. And I think another one is increasing awareness. I think the list can go on, but we try and prioritize, based on what we think is feasible and based on funding.
Yes.
My question is also for Dr. Krishnani, talking about CRIM status. What is the margin of error for that testing? So if you have a child that is less than 1%, could that child actually be CRIM negative?
Yes, I don't think having less than 1% activity is typically what we see in babies with the most severe form of the disease. Of course, it has also been reported in some late onset patients. So just having low enzyme activity does not really relate to CRIM status. I think CRIM status really relates to the underlying genetic mutations, whether you're going to make any protein or not. So although the enzyme assay is very good, I don't think it can tell you 0.05 from 0.1%. So this is done by a specialized way where you take the skin cells and you put it up and see how much protein is there. And we are actually trying to now develop a more rapid way by doing it by a blood-based assay. And I think so far the information has been pretty reliable where the mutations and the CRIM status seem to be adding up.
I guess further to go on that, are you saying that the CRIM status, a negative CRIM status, that would be a null mutation, right? Or those would be all null mutations?
Mm-hmm.
So, okay.
Yes.
With your patients, those were all infantile patients, right? The ones, the good responders, when you had the pictures of the ones that were getting up and walking, they were all the classic infantile patients. So that would be less than 2% enzyme activity level. Did you see a correlation between those better responders being closer to the higher end of that range?
No, as I just pointed out earlier, actually what's interesting is that all the patients, not just those who were less than 6 months, even those who were between 6 and 36 months of age, a number of them had very low enzyme activity, close to the 1%. I don't think that was really what really was determining how these patients do. Because as I said, even a patient who's CRIM negative can have less than 1% as a patient who's CRIM positive. Yeah. I don't think that's what's really driving the response to therapy.
Any idea that what may be the underlying factor there?
Right, that's exactly what Dr. Van der Ploeg and I were talking about. It's really, I would say, the stage of the muscle pathology. But I think there are some negative prognostic factors no matter when you start, and I think one of them is the CRIM, which I think we're all getting a better handle of as time is going on, that you can start a CRIM-negative baby as young as 2 months, as we were able to show, and they still develop very high antibody titers, and they still continue to decline. They initially do well, and then they do decline.
Right. I guess this might be kind of a hypothetical question. It's my last one. Is if you could have your choice as a patient, say an infantile patient, would you rather have a slightly higher or a higher enzyme activity level, or would you rather have early start of ERT if you could make that choice? I know.
Having more residual enzyme activity really takes you away then from being CRIM negative. I mean, clearly all the adult patients are CRIM positive, and the majority of the infantile patients are also CRIM positive. I think I really do need to say this. What we think is between 20 to 25% of infantile patients are CRIM negative. But I think all adult patients are typically CRIM positive.
Right.
So this is an issue that we have for a subset of patients, but I think, as I said even in the talk, is it's going to have broader implications, because if we're able to suppress the immune response, maybe we can get more effective delivery with a lower dose for even the adults.
Okay, thank you.
Any other questions?
Concerning the best moment of start of the therapy, do you still actually have criteria when this moment will be?
I think in infants, definitely it's important to start as soon as possible, and preferably within the first weeks of life. And I think that, in my opinion, makes the main difference, to start at a time point that these patients are doing relatively well, and at a time point that the pathology is relatively mild, as far you can say it in an infant, because I think the pathology in an infant is always severe. When it comes to the older group of patients, it's more difficult and to give a definite answer, because I think we have to learn more in time. And definitely what we have to learn is at what stage of the disease is the disease still reversible. And by time we will learn. As far as we have learned so far, we know that there is some reversibility possible, as you've seen in the various examples. But we don't know exactly where the cutoff point is. And as it stands, I think when there are no symptoms of the disease, I think it's at present too early to start. But certainly, if you have the choice, don't wait until there is severe mobility problems and severe respiratory problems, because the challenges to reverse pathology and to reverse the clinical symptoms will be bigger. Is that an answer to your question?
Any other question?
Yes, for Ans, I have a question for you. If there's a difference between the CRIM positive and the CRIM negative, is there in the future, will they treat the CRIM negative babies?
I think it's a very interesting point, because I think there is still a point of, whether it's a point of dispute. I think it has to be sorted out more closely. What is really the influence of the CRIM status of the patients? I think the data Priya showed were pretty convincing data. But on the other hand, we have to realize that many of the infants have, or in fact all infants, have completely deleterious mutations. And some of these patients make some protein, but the characteristic feature is that this protein doesn't end up in the lysosome. What we definitely know is that each patient who is CRUM positive has the better chance of expressing some residual activity. And especially that holds true for the milder cases. So also there is a factor. Is it maybe so that some of the patients who do better also have a milder course of disease because they express some residual enzyme activity that makes that their prognosis is better? And of course, I can't give the definite answer at present, but I think that has to be sorted out a little bit more in detail.
I would like to comment on this because this has become a real issue for us as treating clinicians in the US as the knowledge of this has increased. And I think ethically as treating physicians, when we have to talk about response to therapy, I do think we have been bringing this issue up, and a number of families do want to know upfront if the child is CRUM positive or CRUM negative. So as a result of that, I think that we really have a responsibility to come up with a treatment for this subcategory of patients. And I think we are working in very close collaboration with Genzyme because they have a number of the cell lines to get a better definition of CRUM. And coming up, and we are working with the NIH, with the National Institute of Health, with the Immune Tolerance Therapy Network, as we're speaking, to try and come up with treatment interventions before we start enzyme therapy in the CRUM-negative patients right now. Because what we are seeing so far is pretty standard. We've not seen a single CRUM-negative patient to date who continues to respond well to therapy. So it's a real concern.
On the opposite end of that spectrum is the late onset compassionate use for the disease. And in the medical field, do you care just as much about those people? Not care just as much, but is the information needed as much? Are those patients still encouraged to take the ERT even though their prognosis is poor at that point? I don't know how many patients there are that are already ventilator-dependent, non-ambulatory, that are being treated, but I wondered about that.
And you're now especially focusing on the older patients who are ventilator-dependent. What I think is what's very important is that we have realistic expectations. And I think one of the things, of course, we can't discuss everything, is that we have to realize that once there is severe damage of, and the process is at a far advanced stage, that it's not realistic to assume that that the symptoms of disease will be reversed to a large extent. On the other hand, we also have to be cautious there because we still have to learn. We also have seen that it takes very long before you have the full effects. And with these realistic assumptions, with this realistic information to the patients, it's different when you treat an adult or an older child with enzyme than these infants who have this fast progressive disorder, who are bound to die. And there I think we as clinicians have a responsibility to see what are we giving to these children. And what I try to show you is that these infants have a very fast progressive form of disease. And especially in these infants with this fast progressive form of disease, it's very difficult to intervene. And even at the end, there is a risk that you lose the battle. In the adults, the disease is slower progressive and there is more variation. And as far as I've experienced, virtually all the patients experience some positive effects insofar that it maybe is not so that they come out of their wheelchair and walk around. That's not realistic, or that they can throw away the ventilator. But what can also be very important is that they can start to to have their social life again and to go out with the family. For example, what I've experienced in a patient, or that they are bedridden, and after enzyme therapy that they are able to go out, have dinners, just be on social life. And I think there are, Tiffany can also explain to you what the effect of enzyme therapy has been. And I think there the patients have to speak for themselves, have to see what happens. But I think that's the situation.
Yeah, I agree with Ans on this completely for the late onset patients. I mean, even for the ones who are very, very involved and are in the wheelchair and require ventilator support, we still have seen benefits in terms that they feel better, they're eating better, they're able to come off the ventilator for a smaller period of time. For a small period of time, their rate of infection or getting pneumonia is much less. So the response may not be as dramatic if they had started earlier, but they're still, I think, I would still say we should still give it a chance and see how they do.
Yes. Yeah, Anna, yeah. First. In the front. Yeah.
I'm losing pounds here.
In the adult onset, what is the speculation as to why symptoms start at such varying ages? Is there any idea as to what's that due to, that it might start with one person in their 20s and then as late as 60? Do you have any idea what that's from?
I think that's still, the majority of patients with late onset Pompe's disease have the same set of mutations. And they all express residual activity. And to make a long term short, we don't know exactly. And genetic factors, genetic background will play a role. We are not all the same people, and also your genetic background may influence, and maybe the type of feeding, and maybe the type of exercise, maybe the type, the way your fibers are built in your muscles, all plays a role.
Okay. Yes.
I don't think I need it. On the late onset, the reaction from the enzyme, even though it's unknown, since the adult form has the therapy has been late coming, is it the improvement of the enzyme does to the muscle? Does it clear the glycogen of the muscle? Is that the main thing that it's doing in the adult form, such that the muscle that's still there can respond better, or along those lines?
In fact, we don't know, of course, exactly, but the main target is indeed to clear the glycogen from the muscle, and that may lead to stabilization or something like that. But it also is targeted to regeneration, so that the muscle are able to rebuild because the storage process is stopped or doesn't proceed anymore.
Yeah.
But as far as the glycogen, once it's relieved, does it improve action of the muscle that's still good, or do you have to regenerate?
I think the best information we have really is from the infantile and the early juvenile patients who have been treated. I mean, clearly there are a host of other factors which are very important, but the most important one is also that you're going to clear the lysosome of what is accumulated there. And we've been able to show that, at least through the biomarker studies, that as the HEX4 or the biomarker levels come down, it has correlated very well with the glycogen in muscle biopsy. So I definitely think that clearing glycogen is important, but ultimately how that's going to translate to response also depends on the underlying state of the disease of the individual, the fiber type and other factors, but clearly also clearing glycogen is going to be an important one.
Okay. So now I can help.
You touched briefly on Dr. Sloanim's research on diet and exercise. How is that going to correlate with the enzyme treatment, and how important is the diet and exercise in conjunction with the ERT?
The process of muscle degeneration, I think, is very complex, and we will hear more about it in the oncoming lectures. But what's definitely true, and that has been published in various publications, and you can also see it when you do it, is that when you immobilize somebody, or when you put a leg in a plaster, for example, then you will lose your muscles, and there will be atrophy, so the muscle mass will decrease. And that's also when you put a patient, for example, in an intensive care and you don't give proper feeding, then that's a moment that there is a lot of proteolysis and the degeneration of muscle tissue. So in that respect, it's very important to stop this process of degradation. And at least if you immobilize, you know that there will be atrophy. And if you don't eat properly and you're catabolic, you will need proteins from your muscle, so there will be proteolysis. So in that respect, it's very reasonable that you have to take care not only for getting the enzyme, but also for mobilization and for proper energy intake. And that's in fact where the publication of Dr. Sloanim focuses upon.
Does his publication give you a guideline for what proper diet is?
Okay, Dr. Sloan very much goes for the high protein diet, so I think many of the people maybe take it. At least I think it's very important to have sufficient energy intake so that you're not in a catabolic state.
I'd like to add one more comment to that, and I think Don Phillips tomorrow will talk about it, but how much exercise is appropriate is also very important, because as we are seeing some of the patients with Pompe disease, too much exercise is also going to be detrimental, as is under-exercise. And I think the second component is also depending on the amount of underlying osteopenia that the patients have. We are noticing that some patients with Pompe disease have developed fractures, and I so think that working with a physical therapist with experience who can tell you, you can't just suddenly from doing nothing do a lot. I think it has to be graded, and it has to be done based on it has to be individualized, I believe.
Okay.
Osteoporosis in adults and osteopenia in children, so it's lower, and that's an understood. And I think what we are also seeing is that it can improve over time as the muscle strength improves. So I think that's the important thing also to recognize.
More advanced forms of osteoporosis can be a result of late onset, because I've been taking injections of Forteo for like a year and a half because they said I had really severe osteoporosis, and I just found out I had Pompe in July. But those were interconnected?
They're interconnected as in any other muscle condition or any other condition where there's lack of muscle mass or lack of exercise, which is very important to maintain bone integrity. And so it's an earlier onset, I think, of osteoporosis that we see, or a risk that was there. We see it in Duchenne muscular dystrophy, we see it in other conditions. So I don't think it's just specific to Pompe. I think it's specific to neuromuscular conditions or any condition of prolonged immobility. I think the good news is that at least in the infantile, where we had least suspected it, we are actually starting to see improvement as the patients are starting to walk. Thank you.
I just had one other, kind of going back to what we were talking about, cross-reactive immunological material, CRIM status. Is that, maybe I should probably already know this, but CRIM status, is that a measurement of the response from your immune system, or is it a measurement of your enzyme activity level?
is a measurement really of the underlying protein, how much protein you're making, how much enzyme you're making. And in turn, what we are seeing is the response to therapy is different, where the immune response that you mount is much more if you're CRIM negative than if you're CRIM positive.
Okay, so that's what they're going on,
Yes.
right? Because you have a higher immune response. So
Yes.
you don't see a lot of CRIM negative adults, or there are none. There are no.
There
okay.
shouldn't be.
In fact,
Thank you.
CRIM status is determined by the type of mutations. If you express true CRIM negative is a patient who, if you express a mutation in vitro in a cell culture system and see whether there is any synthesis of the protein, and once there is none, for example, which may occur when the messenger is unstable, then there is no protein synthesis, and that's the true CRIM negative patient.
My question is for one of the Genzyme gentlemen. Do you have an expected date at which the LOTS placebo study will be submitted for publication? I know you can't control the actual publication date.
The publication itself? Yeah, so I'll answer this. So this is the late onset treatment study, which we are hoping, based upon an evaluation of the study and our new submitted adaptive design to the FDA, that we will have this completed in March, but it is designed so that it could extend longer into the year, and then based upon that interim analysis, and when it does get completed, then the publication would come. We would seek to try to have an abstract written as soon as possible and submit it to one of the major medical meetings, where then it becomes publicly available, and then follow up by a full manuscript publication. So depending upon the completion of that trial, we'll do that. So our plans at this point is the study will complete in March. That is what we intend, and we are planning to have the abstract presented in the third quarter of next year. But we'll have to see how that new adaptive statistical design pans out.
Did you have a question? Yeah, there were seconds. Yeah.
If we haven't filled out one of the IPA surveys because we were diagnosed after all that happened, is there a way to still become involved in the survey data, or is that something that is completed?
Yes, sure. Yes, it's certain possible for you to still participate either in the Pompe registry, or actually and in the Pompe registry and in the IPA Erasmus Pompe collection. You can participate in both, even if you didn't participate before. Please do it, because we need all your help to get all the information you just ordered.
How do I get signed up to do that?
We'll sign you up.
Okay.
Yep.
Next question here.
Hi, my question is for the Genzyme gentleman. I personally was involved in the Mount Sinai adult onset study. I was actually their first subject, so I started in the beginning of November of 2005 and was told that after 12 months of treatment, you would be switched over to the real medication, of course, without being told. And that changed in approximately April. I was told that it was going to be extended and it was going to be a minimum of 18 months to possibly longer before anybody in my situation would switch over. I thought that that was extremely unfair, and I was very frustrated with that because I already put in 8 months. In my particular situation, it happened to work out that because of that and my own personal belief that I was on a placebo, I chose to pursue the medication through my insurance. And fortunately, Genzyme was extremely helpful, and it did go through. It didn't take that long, but about 2 months, and I was able to switch over to the real medication. I just wanted to kind of let you know that from a patient perspective, that was very discouraging, especially because I was pretty convinced that I was on a placebo. My second question is that I have to have recertification by the end of the year, and at this point, I've had 8 infusions, and although I don't notice anything physically, I do have less headaches, and I'm taking less medication, ibuprofen for basic pain. What kind of expectation are they going to want to see in order to recertify so I don't have a problem with continuing with the medication?
From your insurance company?
Yes.
What you need to do is contact your case manager. Have you been working with your case manager at Genzyme?
Yes.
Okay. If you contact them, because some insurance companies do not, you don't need to have recertification, and some do. So it's dependent on what the policy is of your company. And then, we can go through, or your case manager will go through and find out exactly what they need. Sometimes it's just an update from your doctor that, yes, you're on treatment. It's no more than that.
Okay.
So really contact our department, and we can weed through that.
I was just concerned that if the insurance company didn't feel that they saw enough of an improvement, that they would take it away, or something like that.
Just to add to that, in my experience, I've never seen an insurance company deny it after they've already approved it. It's kind of a formality. They just want updated clinical information just to extend that authorization. So I wouldn't be too concerned about it, but obviously contact us so we can work with you and your physician to get the necessary paperwork to your insurer to avoid any delays come the first of the year.
Thank you.
Would you like us to comment on your first thing?
Sure, that would be nice.
We really appreciate everyone's commitment and understanding to, I think, what we all must see, occur. In that we're in a precarious situation where our limited understanding of the disease was such that, we thought maybe we could really show a difference in 1 year's period of time for placebo control. And we really thought about this with experts on, well, what would happen if for some reason the small population in which we chose did not see enough response clinically in that 1 year time. And if that was to occur and we didn't do that, everybody, long-term therapy would be at risk. And so we brought it in with expert opinion and statistical consultation to see, could we do this another way, knowing that we'll never be able to do a study again. And with lots of discussion and angst and some of the strategic decisions that I think the woman from the FDA just talked about us inside, and in discussions with the FDA and others, we thought it was best to use a new technology, a new statistical methodology that would allow us to potentially have an independent look at the data, not Genzyme, an independent statistical consultant, and look at the power calculations associated at the interim of time and determine whether or not maybe you would see a clinical response, not at 1 year, but maybe at 18 months or 2 years. And that probably was something that would be of great sacrifice to everybody in this study, but maybe our only chance to ever prove this. And so we've put a number of patients enrolled in the study, in a very difficult situation, and we cannot be more grateful for that. But from your perspective, it must be very difficult. And there are others who must be thinking about this all the time and wondering, when you hear a message, treat early, and you see other people and everyone's talking about it. But it's really a sacrifice, if you will, I think, that we're counting on and everybody's counting on, because we're afraid that we'll never be able to answer the question otherwise. I know it really gets confusing when you hear things from the company through physicians and clinicians, and it loses translation, and that's challenging for our communication. We're sorry that that ended up coming that way, but this is kind of the spot we're all in. And we really hope to finish out successfully and not have to do this again. The challenges of developing a product in a rare disease.
Thank you.
questions? Yes.
Are there going to be any more clinical trials?
Yeah, I briefly mentioned some of the clinical work that we'll continue to do. There is no plans at this point to do any placebo clinical control trials, and I think that is what, is required by the FDA in order to show a difference, because you have a comparative, and they would not accept. We were able to get away with this because of the ethics and natural history data that we've been able to demonstrate in infants to show the rapid deterioration. But we weren't able to show enough compelling data to avoid a placebo-controlled study for the adult population. We will be doing some more work, though. We'll be following up the infants for a very long period of time. We need to do some additional dosing evaluations on individuals who are not really seeing the response that we had hoped. We want to better understand the CRIM-negative patients themselves and how we can intervene with some immune tolerance protocols and maybe reverse some of the poorer outcomes that have been seen there. And we want to continue to study all of these patients, everyone in the Pompe registry, which is really not subjecting anybody to clinical trials. It's just observing routine clinical care and analyzing it appropriately. So at that point, that is what we're focused on.
Other questions? It's your chance.
Thanks, Arnold. I'm not exactly sure who could answer the question. It's just pertaining to insurance. If for some reason your insurance coverage did expire, or for some reason you were dropped, say for whatever reason, and Myozyme was no longer being paid for, in the interim, when you had no coverage, trying to gather new coverage from other sources, whether it was government sources or another private provider, would Genzyme would they stop the Myozyme infusions, or would you still be infused until, and then you'd have to sort of retro the payment from the time that it happened, or would you not have to be responsible for those infusions?
Yeah, we definitely want to work with you to help you find health insurance, because you need it regardless of your Pompe disease, and that's our main focus with GTS. But Genzyme does manage a charitable access program that is available to individuals that don't have health insurance. It's based on financial and medical need, and it is considered a temporary program until we can help you find alternative health insurance. So that would be available.
Okay, great, thank you.
So just to reiterate, with constant monitoring and understanding where any individual might be in their plans, we would proactively present that so there will be no interruptions in therapies to our charitable access program.
Yes, another question. Hip. Ladies first, ladies first. You're stealing.
My question has to do with the delivery of the product to the infusion sites. With the world as it is, there could be some crises. How much is actually available per patient at an infusion site?
Yeah.
And how quickly can it get there?
I could make a joke here from a marketing standpoint. I'd like them to buy as much as they could do. But, really, we offer the product, and it is up to the pharmacy at every individual hospital to decide how much inventory they would like to store. So, so I think that, we recommend that they have an ample supply, at least 2 infusions worth on hand at all times. There are times where they will only take 1 infusion, and that is why we have our, right immediately after infusions, we have our pre-call program, and just to make sure we immediately supply that so there's ample time before the next 2 weeks for the next infusion. So we will work with anybody to help manage that. So far, we've been able to be in this business for 15 years with upwards of 7,000 patients with infusions every week or every 2 weeks throughout the world, with having, very successful results with making sure that nobody misses an infusion because there's out of stock at a hospital. It does occur. We had a few cases at 9/11, and so disasters can happen, but it was quite manageable, and overall we're able to make those up in a few days or so. We're reliant, of course, on Federal Express, and we have a full contingency program on working with how to ship our products out and making sure we have alternative sources, either ground and air or air transportation. But I think really our hands are a little bit tied on how much inventory any hospital would hold, except beyond our recommendations and the programs we have in place to ensure that supply is available.
Sure. My question relates to home infusions. I mean, obviously the infusions are 4 hours. There's several hours on the front side for patients waiting, and then you can sneak out quickly after, wait another hour after. So I guess, is home therapy infusions coming sometime, you think, or is it just too far out there with insurance and everything?
Well, I'll turn it over from an insurance standpoint, but just from our position is how you receive your infusions is really a decision between you and your doctor at first. Based upon our label and our indication, there are some hypersensitivity risks associated with our product, and so we have to make sure that wherever it's delivered, there's appropriate medical care available in case that should occur. There are some reimbursement situations associated with that, though, but it's really something that I think I'll turn over for the case management team to maybe discuss if you and your physician feel that that's appropriate.
If you and your physician do feel it's appropriate, we will contact your insurance company. Most insurers do have a home care benefit to them. How it's carved out and what it means is different for each company. So they may need, information and make sure it is a doctor has approved that. The other instance would be finding a home care agency that would take on a patient that could take up to 4 hours. But we have done that with our other products. So it's doable, and again, but it is facilitated by your physician and yourself discussing that. And then we would, if someone called us and said, we want to look into that, we would look into that and see what's necessary by the insurance company to facilitate that for you.
More questions? Yeah, one here.
I have a question about whether or not Myozyme is light sensitive. GSDNet has had some talk whether or not it should be covered and protected from the light. In Genzyme's brochure, it says it should. We've not protected ours. How do we find out?
How do you find out whether or not it is indeed light sensitive? Yeah, I think I'll make a statement, but then I would maybe refer that question to our medical information department, which is really the same number that you saw all of those numbers go to the GTS number that was flashed earlier. I am not part of the regulatory team or the medical team to develop this, and maybe I could call on others, but it's my understanding that when you don't complete every single study on the light sensitivity, that is, we've done studies on light sensitivity of Myozyme in the vial without it being as the cake, and they was fine, but I don't believe we did an official study, and we would have to take another 6 or so months in order to complete that study and do the stabilization. So we chose not to. Didn't want to delay things any further. And what we ended up with is the FDA coming back and recommending, well, since you haven't done the studies, you don't really know, it probably makes sense in order to cover that up during that infusion time. So that was what they're, if they don't know, that's what they recommended. So otherwise, I think we should probably look into our medical information and find out and get an answer for you on what specific studies we have done and what we do know about light sensitivity.
This is only for the U.S., not for Europe. That's what I understand.
Yes, I don't believe it's in the label in Europe. So each regulatory authority has different requirements and what it is necessary before you, in your submissions, yes.
Hi, this is not really a question. I just kind of wanted to share with any other adult patients that might want to pursue Myozyme through their insurance. I have Blue Cross Blue Shield, which I guess on the East Coast is pretty popular, and ironically, Genzyme was going there just to do their Pompe awareness with the medical team there, and there was a statement written in the booklet already because of the FDA approval, the way it was written, that there will be no coverage for adult Pompe treatment. And so we were just getting ready to submit my paperwork, and because I had symptoms my whole life, we switched it to juvenile onset, and that seemed to be helpful in getting the approval. So I'm sure all of you can think back and see that you've had onset for many, many years, even though it wasn't diagnosed until you were an adult, and that may be helpful. I just thought I'd share that because that seemed to work for me. Thanks.
Okay, if there are no more questions, I would again like to thank the speakers also for the discussion, and we will reconvene coffee break now at 3 o'clock.
What if the cough assist doesn't bring the secretions all the way up and it stops in the throat? Have you ever had that happen? And if it did happen, what would you do?
Yeah, well, it can stop in the throat. It can stop in the mouth usually. You can just suction out the mouth, or you can spit them out. It'll bring them up to the mouth.
I'm just saying that because my daughter coded on the cough assist before she was trained. She absolutely coded on the cough assist. And because she was sick, she had bronchitis, and it brought it right up here, and she couldn't move in any ear whatsoever.
All right, tell me, what pressures were you using it on?
At that time, she wasn't ventilated.
No, on the cough assist.
It was 30.
30, that's very low.
It was 30.
Also, tell me exactly how you...
At the time, she was 8 months old.
Oh, she was 8 months old?
Right.
Oh boy, no.
It was somewhere...
It's not clear. See, it's very unclear that it helps at all for children that small.
Okay.
I've seen an 11-month-old that allowed it to work. And what I mean by that is the baby just lied there and didn't cry, kept the airway open, and it seemed like the baby was allowing it to work. But I've never seen anybody less than 11 months old who wasn't crying. And it's not going to really work if you can't cooperate with it. Now, many of the mothers and some of the respiratory therapists swear that it helps the babies anyway. And I don't think it'll hurt them. But I'm not convinced that under 11 months of age, or even under 2.5 years of age, that it really makes a significant difference. What you have to do, though, for it to even possibly help, is you've got to time the machine to the baby's breathing. So in other words, when the belly goes out, that means the baby is inhaling, and you give the positive pressure. Then when the belly goes in, the baby's exhaling, so you do the negative pressure. But these kids are breathing at 50 times a minute, which means you got to capture them, 1 time a second. It's very, very difficult, and that's why I'm not really convinced that it does any good. But again, some mothers and some of the respiratory therapists feel that it may help, but there's no objective evidence of that. Now, the other thing is that the most common mistake is people don't press on the belly during the negative pressure. So you did use pressures that were too low, but you probably didn't have it coordinated with the baby's breathing anyway. And you probably didn't press on the belly.
What you're saying is that at that age, it's almost impossible to do.
There's no evidence that it's really helpful at under 2.5 years of age.
May I have another question? Okay.
Hi, also a question for Dr. Bach. I currently use BiPAP settings 24, and I really like the feeling of getting that very deep breath, and have found that every time I've had my pressure setting on the inspiration increased, I get at least a temporary boost on my pulmonary function testing that will last for 3 months, 6 months or more before it will start to decline again. What is the safe upper limit for pressure?
First of all, wow, that's very great that you mentioned it, because the deep breaths will allow your vital capacity to increase because you're improving the elasticity of your lungs. But if you want to see a much better effect, then you really need to get deep breaths at much higher pressures. And what is the safe upper limit of pressure? You can never go close to it. It's at least 90 centimeters of water or more. And even on those AMBU bags, the pop-off valve is usually set at 40 centimeters of water, far too low. So you're not nearly expanding your lungs to where they should be expanded. Now, what's your vital capacity roughly? What percent?
It's about 46%.
Okay.
It's about 1.7 liters.
Okay, so that means you're not expanding half your lung.
30% when I lie down.
Oh, okay, but see, even when you're sitting, you're not expanding half of your lung, even if you take the deepest breath you can. So you need the pressures of 50 or 60 centimeters of water to fill your lungs with air sufficiently so that you don't get atelectasis and your lungs just don't close down.
Okay.
See?
Second thing is I do have a cough assist and had gotten it after a bout with the cold when just terribly fatiguing to cough and cough and cough and not have something functional happening. But I very rarely get a cough.
Right.
So I use the cough assist on a daily basis, though, just for the inhalation, the expansion of the chest wall. I'm doing that at pressures of plus and minus 40.
Well,
Is
that's
that appropriate or should it be?
Yeah,
up?
40 is the minimum, but that's fine, that's fine. But you know, if you had a better machine than a BiPAP, you wouldn't need the cough assist for that. See, the BiPAP is limited to a low pressure, so you can't get the real deep breaths with the BiPAP. But if you had a volume machine instead of a pressure machine like BiPAP, then you could air stack. You could get a breath and hold it, take it up. Then you can even expand your lungs overnight, and your lungs would be healthier because you'd be able to expand them whenever you felt like it, instead of having to wait until the next morning to use your cough assist for the deep breath. You see what I'm saying? If you had a volume machine, you would take a volume and hold it, get another volume, get another volume. You can put 4 liters of air into your lungs that way. But you can't do that with BiPAP, so you've got to wait until the next day to get your cough assist for the deep breath. So you really shouldn't be using BiPAP. BiPAP is more uncomfortable, and the expiratory pressure is not good.
I've maxed out my machine anyhow.
I think there was another question here. Yes, here.
For Ms. Phillips. For Ms. Phillips, my daughter's legs started freezing up at 20 and she's 29 now. Is that reversible through what you're talking about? Can she get some of that angle back?
It depends why her legs are freezing up. So are you describing it in terms of tightness, shortening in the muscles?
Right.
Yeah, I mean, definitely. You always want to try to do passive range of motion and massage and anything else you can in terms of trying to increase that range, because what will happen over time is she'll just continue to get tighter.
Dr. Bach has said that he would be available for any private conversations that you might want to have. Is there anyone else who has a question? Are there any further questions? Yes.
I have one question. A question for Don Phillips. Just before I came to the U.S., I got a stand-up wheelchair, and I'm in a wheelchair for I don't know how many years or ages. And I have severe lordosis, scoliosis, contractures. And I was wondering how far can I try to improve get rid of the contractures, get a better ability to stretch my muscles, etc.
So you've been sitting for a long period of time.
Yeah,
and
your lecture was more only about infantile onset patients, and I'm not one.
Right.
And I'm really willing to improve,
Right, and so you want to see what can happen over time. So the whole goal is just to take to find a way in which you're comfortable to get some elongation on those muscles, and then to see if you can tolerate it and gradually move into a new range. So it would depend on how progressive those contractures are. I mean, some kids use serial casting, some adults use serial casting to try to get increased range of motion. Sometimes surgery is indicated for patients in order to have as significant changes as you might want. But I would start with just allowing yourself within your new chair to go to the end of that range and tolerate it for longer periods of time and see where your muscles go to.
Also, do I need to do it 6 to 7 hours a day?
The 6 to 7 hours a day we use, no, you can, studies show that you could stretch for 5 repetitions, holding it for 60 seconds, 5 days a week, and make a change in your range of motion. The 6 hours a day is when you're also using it functionally. So for a child that's putting a stretch on that heel cord while they're walking, and maybe also wearing braces, and maybe also has a therapist stretching them. So we use the 6 hours a day sometimes as an indication for night splinting, which I think is something to consider in this population in terms of you may not want to jump to wearing AFOs while you're walking, but you may want to try them initially, either AFOs or knee splints, as a night thing where you put them on in order to elongate and see if you get some increased range at nighttime. And then see over time if you can use that functionally.
Can I ask a question? Aren't there physical therapists who could act as a teacher, a doer,
Absolutely, yeah. Do you
I
get
don't-
physical therapy?
Yes, every day.
So can they be asked to help you stretch?
They already do that.
They are, okay.
I mean, it's just that key in terms of how much time you're sitting and how, what opportunity that muscle has to elongate. So you have the most success if you can use it functionally. So the idea that you have that chair, I don't know if other people are familiar with her chair, but it's going to allow her the option to go from sitting to standing. And it really is a great chair if you have a chance to get those. And it allows you also to help, so it really helps with standing transfers.
There was another question here.
Do you have like a website address where I can go and get more information on what all you just ran through really quickly?
I'm sure I could find a way to post that PowerPoint or the last slides, because I think there was a lot of information on those last slides about cardiovascular training. And I think that's really important in this population in terms of submaximal training and what that means and how you set guidelines for yourself for that.
I just wanted to make a quick comment. There's a physical therapist who recently published in Genetics in Medicine on guidelines very much close to what Don just spoke about.
It just came out in 2006 in Genetics in Medicine, and you can get some information from there too.
Yeah, I don't know if it has some stuff, but I don't think it has how to get your heart rate and how long you should exercise for in terms of submax, but it has some guidelines, yes. And it's very thorough in terms of range of motion as well.
No, I was just going to say, you can also get a lot of information about this from my book on management of patients with neuromuscular disease. The University of Southern California, Davis, for 30 years has had a grant, a model neuromuscular disease grant, and basically 90% of what they've done in research is on exercise. And all of this, anyway, is summarized in the book.
So in other words, this will be posted on the website?
If you would like it to, that certainly is something that we could do. I think there's good information.
Is
Put it like on the IPA website?
that's what we're talking about? Yeah.
Somebody
On the-
afterwards can talk to me about how we should do that, and I can go ahead.
Are there any other questions?
I don't need my.
Okay. Yes, I know. You did that this morning.
As far as for Sharon on swallowing, my wife, this summer, we had to make a mad dash to the ER. Having eaten a sandwich of subs, got built up over the windpipe and was not able to cough. We didn't have our defibrillator with us. We were like 20 miles from home. What would be the best procedure when something like that happens? We actually did call the ambulance, and she desaturated down into the 50s on oxygen. We were able to put some oxygen into her ventilator.
I think once you get to the point of having something going down the wrong way, there's, other than coughing either assistedly or not, what you have to do is blow it up from the airway entrance. Taking care with what you are swallowing, chewing carefully, taking your time is the best preventative thing.
Yes.
But once you get to the point of having something go down the wrong way, really you're trying to get maximum upward airway movement.
Well, they tried to Heimlich, and it was not plugged to the point where Heimlich did anything. It was just kind of laying there and creating mucus. So,
I don't know what else to tell you. Did she ever have a swallow study? just to look at the dynamics to see if it really was only that there was a loss of the bolus control and some piece sort of broke away, or whether some other muscle function problem that maybe can be dealt with in another way. That might be something to consider.
Question for Dawn. I stepped out and missed the end of your presentation, so I apologize if you covered this, but question goes to using weights. And a couple of patients I know, patients are using weights and fairly strenuously. I've been reluctant to go over like 10 pound hand weight, and wondering if, as you go, if you increase strength, are you risking tearing a muscle and really hurting yourself, or what do you feel like using weights?
So I do have some slides that point to that, and I mean, I think we don't know a lot from the research, but what I was recommending is that you do a lower resistance, higher frequency training in terms of being in the endurance piece of it, because your energy substrate that you're going to use changes with higher resistance, and so you want to be burning more fats. And there's also the question of what type of muscles you're recruiting, and so with a higher intensity, you may be recruiting more type 2 muscles, and we're just not exactly sure what's happening in terms of, they're going to discuss it tomorrow, glycogen clearance in terms of type 1 and type 2 muscles, and at what point with high resistance exercise you're going to potentially do some more muscle damage. So I mean, when I'm working with the kids, and my recommendation for late onset would be to look at the range that you work in and first increase the repetitions in that range, and to stay away from high resistance.
Are there any more questions? If not, I'd like to make a comment. I mean, it really strikes me that we have been going into some areas where there really is very little hard data to tell us which way we should go. In other words, what is the best type of exercise? I don't, we don't have the equivalent of two different trials. Maybe we could acquire this kind of information in the natural history study. I don't know, I will be very anxious to hear whether the natural history study includes some discussion of the type of exercises that people are doing. And, I think that we have to think about how do you approach getting information that is more than opinion, or more than, yeah.
I'm sorry. Again, going back to...
I'm not discussing the pulmonary.
No, I'm not talking about pulmonary. I'm talking about the exercise. For 30 years, the University of Southern California at Davis has been studying almost purely exercise and neuromuscular disease in all types of myopathy patients. They have consensus conferences every 5 years or every 4 years, and they get renewed. And they have done a great deal of research in the area. And the fact of the matter is, what they know is that if your muscles have greater than anti-gravity strength, you can increase the strength with resistance exercise. But they don't know if you're going to subsequently lose strength like this, parallel, or end up non-functional at the same time, or even damage the muscles to the point where you could actually lose strength sooner. They've done extensive exercise, they've published entire issues on the subject, and there's still no knowledge that's really come out of it to make any recommendations other than they encourage people to do what they can do, and that's that. So if the muscles have greater than anti-gravity strength, you can strengthen them by exercise, but we don't know if that's beneficial for the long run. If the muscles have less than anti-gravity strength, we know that you cannot strengthen them, and then by just exercising them, you're overworking them, and that's probably going to be, if anything, more harmful than good. But there's a great deal of exercise literature on this subject.
Is any of this in Pompe's disease, or is it, you think?
No, mostly muscular dystrophies.
Yeah, well. Are there any other questions?
Polio.
Anyway, I thank the speakers. I apologize for having it run over, but I really found some of this very, very interesting, and I lost track of time. I just want to make a comment first and then ask some questions. It would be very interesting and important, I think, to also try to determine the rate of loss of miscarriages, if that would at all be possible in there. Just saying for whoever is doing the survey. I have a question for Nina Raven first, and then for Dr. Chen. Nina, I wonder, you have said that autophagy
is a starvation response. And I wonder if you would like to speculate as to the nutrient that might be eliciting this starvation response, whose absence might be elicited.
The short answer to your question is that I actually don't know. But the long answer is we speculated that, so we usually think that the glycogen accumulation in lysosomes does not have any metabolic consequences for muscle cells. But in fact, the glucose which is released from the lysosome as a result of acid maltase activity may be important in terms of the supply of energy for skeletal muscle. And we're certainly not talking about the global effect, because there is no hyperglycemia, and we all know that. But we speculated that there is a possibility that a shortage of glucose in a very small segment of the fiber may initiate the autophagosomal formation. This is one of the possibilities. There are certainly many others. The fact that we see a tiny lysosomes in the core of the fiber, and they already at a very early stage seem to be unable to fuse and digest the content of autophagosomes suggests that could be some other abnormality. For example, the pH of this lysosome, the membrane permeability of this lysosome. And then what may be happening is that autophagosomes, which normally detect damaged organelles in the cell, like for example mitochondria. Mitochondria is taken care by autophagosomes. This is the only way to get rid of damaged mitochondria. So it's possible that autophagosomes see this lysosome as damaged organelles. And they come as a protective mechanism in the cell to get rid of them. But they can't, because eventually they themselves should be eaten by the lysosome. And this is what's not happening. So there are other hypotheses, and I would very much like your and everybody else input into it.
Well, a number of them might be testable and lead to alternative adjunct therapeutic measures. Okay.
Rochelle, why don't you continue on that thought? I mean, you say you have a variety of ideas that might be testable, such as?
Well, for example, you might be able to do in vitro experiments in which you manipulate the concentration of glucose within the myocyte and see whether that alters the incidence of autophagy. You know, you could go on. Yes. I mean, I noticed that you mentioned AMP deaminase as being one of the enzymes whose expression is altered. And that certainly is a molecule which might be very important with energy necessary for autophagy. So I mean, you can go on and, flights of fancy, but they might lead to something that might lead you to something that you might be able to manipulate, and it might have a therapeutic effect. Now, the next question I wanted to ask is also related to autophagy. And I wanted to ask Dr. Chen what happens to the autophagy in the setting of the neo-GAA, in other words, the more active GAA, and what happens with the AAV vector. And I also had a question, what happens if you give a very high dose of the neo-GAA? Do you get a better response? In other words, because you know that your response is not optimal to the enzyme that you have now. So you've then tailored the dosages to give you the same response as with the original. What happens if you up the dose of that GAA?
So to kind of address your question about autophagy, I think the process I think also occurs in the context of neo or gene therapy. I think the data I shared with you, most experiments we did were performed on animals who were much younger than what Nina showed. So I think my response would be that if you intervene early, you can perhaps reduce the influence or contribution of autophagy in the problems that Nina explained. And I would argue that in the OMAS experiment that we shared with you, where we saw a less than a complete correction of glycogen in the skeletal muscles, could be attributed to the problems that Nina illustrated. So in response to your question about what happens if we use higher doses of neo, I would predict, although we haven't done an experiment, that you would perhaps get greater extent of clearance, at least in the younger animals. I'm not sure whether use of higher doses of neo would address the problems of autophagy that Nina indicated.
I'm sorry, can I ask one more question?
Please.
In the neo, in your experiments with mice, you are injecting a foreign protein when you give human GAA to the mice. But I'm asking the question, when you take the neo, you're essentially providing a protein which is glycosylated, that has sugars on it in such a fashion that it is foreign not only to mice but also to humans.
Okay, that's a good question. So you're asking what happens to the immune response to the protein and also to the added carbohydrate. I would start off by addressing the added carbohydrate. So if you compare the antibody response of unmodified enzyme and neoenzyme, if you measure the antibodies to the proteins, the same. So the carbohydrate moiety doesn't seem to make it more immunogenic. Now, have you looked for antibodies against the carbohydrate component? We haven't done that. And you may be asking, well, how did we get away with a very long-term study that we did for 6 months without the effect of antibodies? I didn't share with you, actually, in that study, we actually tolerized those animals first using the gene therapy experiment. The detail I can share with you, but what we did was we actually expressed a mutant protein along the lines of what Nina shown in the transgenic animals. We first tolerized the animals, and that allowed us to keep repeating those infusions that we did with both the modified and the neoenzyme.
Thank you, it's very interesting to share.
Thank you very much. There's a question in the very back with the gentleman with the striped shirt.
Okay, I actually have a quick question while I transfer the microphone. I guess it would be for Nina. Excellent science, by the way, on all accounts. As far as the autophagic buildup and the glycogen buildup, which is it? Is it both, or is it one or the other? When you have those bodies, there's different studies that talk about glycogen storage and glycogen buildup, and then there's autophagic buildup. Is that the same thing?
No, it's not. And actually, we don't know how glycogen gets to the lysosome. This is a very basic thing, which one would think that we really know well, but we don't. One of the hypotheses that the glycogen enters the lysosomes through this autophagy. And what I described to you, the build-up, is so-called macro-autophagy. So there are different types of autophagy, and it's quite possible that glycogen gets to the lysosome through a different type of autophagic process. There are actually 3 types of autophagy. As I said, I described macro-autophagy, and it is not clear that the glycogen gets to the lysosome through this pathway. It may well be that it gets to the lysosome through another pathway. In this case, which could be testable, and I will in a minute tell you how we're trying to test it, in this case, the autophagic build-up and the glycogen build-up and accumulation would be 2 different processes. Now, the way we are trying to address it, we will try to generate the mice, which are knockouts for acid maltase gene, so the ones which we have. And so these mice will be deficient in autophagy, specifically in skeletal muscle. And hopefully this will give us an answer of how glycogen enters the lysosomes.
Okay, thank you.
Well, that answered my first question I had. It's been known for a while that autophagy plays a role in the storage of glycogen. And I was wondering, I mean, it sounds like you're going to be doing the experiments. How about, have you tried, there are certain pharmacological biological inhibitors of autophagy, like 3-methyladenine. Have you tried that to try and repress autophagy, and does that have an effect on storage?
Very good question. The problem is that there are stimulators like rapamycin and inhibitors of autophagy, but they are all for in vitro use. Unfortunately, they are not for in vivo in animal use. And the problem in the field, my opinion, is that we don't have a good in vitro model to test. Again, this is something which we're trying to do, but it's not trivial, because most people work on fibroblasts. Fibroblasts are extremely irrelevant tissue cells for this type of study. Myoblasts are better, but still not very good. So you need a myotube, which actually is similar to what you have, or closest to what you have in the fiber. We don't have a cell line, an established cell line, either from humans or from animal models, and it's very hard to do. So we do not have a good in vitro model to test multiple chemicals or to manipulate the system to see what we can do.
Okay. And excuse me, and there are no chemicals available for in vivo use at the current time for blocking autophagy. No chemicals available for in vivo.
Available for in vivo.
Thank you.
So my next question, have you tried the converse? Have you tried to upregulate autophagy? And would you expect to see, obviously, I would expect to see an increase in glycogen storage.
That's the question, as I mentioned, which we will try to address by crossing these mice to mice which are deficient in autophagy, specifically in skeletal muscle. Because the mice which are deficient in autophagy in multiple organs are lethal. We cannot do anything with them. So our task will be to create mice which are deficient in autophagy, specifically in skeletal muscle. And with current techniques, you can do it, and then cross those to our knockout mice. And then if the glycogen gets to the lysosome through the autophagic process which I described to you, it may well be that we will not see any phenotype. And it would be extremely interesting.
Could you easily increase autophagy by starving the animals? I know amino acid starvation is a powerful inducer of autophagy.
Yes, and we've done it. So we've seen a tremendous increase in autophagy. But how long can you starve an animal? You can do it for 24 or at most 48 hours. Again, it's a very short-term experiment.
My next question, I have many questions. I'm going to be here a while.
Not much longer. We're going to let you have one more question because we have folks that are really anxious.
How about 2 more questions? Is that a fair compromise?
Very good.
Combine them in one.
Okay. Okay, I'll get to my favorite question then. For same chain, I'm wondering if you would expect there's definitely an increased efficacy of using gene therapy over ERT. Do you attribute that to being an increase in exposure? Is it as simple as an increase in exposure? And if you were to replicate the exposure, that is the activity times time in the blood of the enzyme, if they were equivalent, would you expect an equivalent response?
No, again, another great question. So you ask many facets in terms of that question you asked. So first of all, the quality of the molecules that's generated by introduction of recombinant enzyme we use in the form of myosin and the enzyme we make in situ by gene therapy may be different. So if I argue that the glycosylation is important, those are 2 non-equal molecules. It's one variable that we're testing. But I think the most likely answer that I can give you that's responsible for the greater efficacy that we see in gene therapy is, as you indicated, is the better the bioavailability of the enzyme. So by making it continuously by gene therapy in situ, we could be, for example, blocking the other non-productive receptors and getting better exposure of the enzyme in the muscles where we want it to be. So I think you're asking me to do an impossible experiment is to continuously infuse the muscle with an enzyme and ask if I get an equivalent efficacy. I think the prediction would be it's going to be pretty close if the enzymes are the same.
Thank you very much. And we're going to now move to
I
Priya.
have one more quick question. On the cream.
Yeah.
Okay, Priya Kishani had talked about the cream status and how that affects the response to ERT. Intentionally doing this. I am wondering, when you see a high antibody response to the myozyme, does that affect the biodistribution and the clearance of the enzyme? And is that a factor?
Yeah, so in Priya can chime in if she likes, but there are some effects on the pharmacokinetics in the presence of antibodies. However, the clearance rates don't appear to significantly change, although there have been some cases reported of neutralizing antibodies, and in those cases, then that's a different story. And we certainly see neutralizing antibodies in mice. That's common.
We may come back to you, depending. We're really doing well on time, but we want to be sure that Priya has a chance to talk up here. She's been waiting for quite a while.
Just so you guys know, that's Jared Sabalto. He's actually looking for a job if anyone's interested. He's our GSD-Net scientific advisor.
Sanjay, I think maybe you already answered it, Sam, but maybe I didn't hear it very clearly. You talked about the antibody titers being similar with Neo, JA, and JA with a background of gene therapy, right, when you transduced?
Yes.
So have you done it without that background and have you seen any difference?
It's the same.
It's the same. Thank you.
Do we have other questions? Here. Wait just a minute.
My question is a lot simpler for you. We're biology challenged in RO. Can you just tell us the difference between the type 1 and the type 2 fibers?
It's red versus white meat. If you talk about chicken, that's what it is. So the red meat is myoglobin, rich in mitochondria, fast-twitch muscles. So basically, it's red and white. Yeah.
Okay, with ERT, you talked about uptake in the quadriceps and also the cardiac muscles. How does it compare in the diaphragm?
Diaphragm is a mixed muscle. It's not either type 1 or type 2. It's a mixed type of muscle.
So, from what I understand, the diaphragm is not, the uptake is not as good as any other muscles.
In mice, it was remarkable. The diaphragm, in mice, yes, it was remarkable. The diaphragm always cleared glycogen beautifully in basically any dosages which I use.
Okay, what about in people?
In people, I will address it too.
I'd ask one of our clinicians to answer that. Priya or Hans?
If there is, I can actually, sorry, I actually question for Priya would be because some of the patients unfortunately passed away in this clinical trial of 8. So are there any data on the diaphragms? Yes.
The simple question is, the simple answer to whether the diaphragm response in humans is unknown because you need to take a biopsy of the diaphragm to see how it's cleared. So I think this is unknown at present. In the future, I think what we could see is that the difference between the spine and the sitting position of the APC will change, and that will be an indication that the diaphragm is responding to treatment. So that's the focus for the clinical trial and for the last study, I think, and the long-term follow-up.
But because of clearance doesn't necessarily mean that the diaphragm improves, correct? It should.
I think Priya also has a comment on the diaphragm.
I think as far as my knowledge goes that the ratio of type 1 to type 2 fibers in the diaphragm varies in humans. Anecdotally, I can tell you from the clinical trials in the infantile patients what my experience has been. In some of the patients where we've seen a paradoxical motion of the abdomen with the chest, suggesting that the diaphragm is not functioning as well because it's very difficult to measure diaphragm. We've tried to do it in terms of pulmonary studies in them. What we have seen is that the two patients that did not do extremely well and had a lot of problems with in terms of maintaining oxygenation, there was this paradoxical movement of the diaphragm was much more. In fact, I think autopsies have been done on 2 patients, and there is a massive accumulation of glycogen in them despite being on enzyme therapy. So I think that even a variability of response in the diaphragm based on your type 1 versus type 2 would play a role.
I guess this would be directed to somebody from Genzyme. How close are we to getting gene therapy or this new ERT into human study?
Okay, so with NEO, as I indicated at the end of my presentation, I think where we are today is that we've done a proof of concept that suggests to us that this is an interesting approach. So what we need now to do is to optimize the way by which we can get this done. So, for example, one variable that we really need to show is, have we picked the right configuration of the ligand? So what do we attach? Have we picked the best one? And the second thing that we really need to do is, how do we do it in a way that is very reproducible and very predictable, and it's the same every time we do it? So if we want to take this forward, I think we want to go in with one that is the best, rather than something that is better, because it takes a long time to take this through different stages of approval. So that's what we will try and do as we go forward, and hopefully maybe next year I can come back and give you an update about where we are in that regard. With gene therapy, as I indicated, I really want to classify it as an emerging therapy. Now, although Genzyme currently has 2 gene therapy trials ongoing in different disease indications, one is in Parkinson's, and we also have one in peripheral arterial diseases. The hope is that we'll begin to learn from those trials what the issues are in those very specific indications. There is one disease that we are also supporting in the context of gene therapy trial, and that's hemophilia, which will be somewhat similar to what we would want to do in Pompe disease, in that all we're trying to do is to modify an organ in the patient to produce a therapeutic protein. In hemophilia, it's factor 9. In Pompe, it's GAA. So that program is significantly more advanced than where we are for Pompe, and the hope is that we'll continue to track those programs and learn off those programs as we think about how to utilize it specifically in the context of Pompe. So I'm always very averse to giving you time frames, but we're moving along all those fronts as we speak. And today was just an indication of the ideas that we are favoring and will be focusing on as we go forward. I hope that answers your question.
Thank you.
There are also clinical trials, as you very well know, using AAV in Duchenne muscular dystrophy.
That's correct.
And so again, another systemic muscular disease, and perhaps some of the information that comes out of that will be valuable and so forth, because that's currently ongoing. What will be the FDA requirements for a modified enzyme? Will it be, will you have to start from scratch as far as approvals, or what will be, what's the deal there?
That's likely to be considered a new chemical entity. I think that they would be interested in allowing, this concept of taking myozyme as a base molecule and then adding a ligand on top of it chemically. But I think it would be essentially resetting the clock and would be expected to go through the regular approval process with no shortcuts, because it would be considered a completely new drug.
Which means it'll be essential to have your best candidate. You don't want to do that often.
Absolutely correct.
Because that's a big deal and so forth.
That was a great point. I just had a quick question for Dr. Chang regarding permeability issues as far as getting the enzyme from the bloodstream capillary into the muscle cell. Using maybe vasodilators or, say, exercise or some kind of a physical therapy during when your blood is laden with enzymes. Is that potentially beneficial?
That concept has been proposed, and we have tried a couple of agents. For example, VEGF has been known to permeabilize the endothelial vasculature, and that seems to work quite well for other therapeutic agents, such as for viral gene therapy. Has been shown to work quite well. We actually tried it for myosine, and we did not see significant improvement with that intervention. And we tried other agents as well, and still haven't really found one that really provides us with a major improvement that means something.
Thank you.
Does the autophagy continue once the patient is on ERT, or have you checked to see with the neo-GAA if it would continue, or does it cease once you start on the therapy?
In mice, and I can only attest to what I see in mice, the autophagic buildup is not resolved after months on
I have a naive
Question. The data that was shown by you, Bob, is it suggested that if you start treatment really early, can you prevent some autophagic buildup between you and I mean, is there any data to suggest that you could help in any way by starting very early?
So our pathologist, Beth Thurberg, if she were here, she would say that by treating early before the pathology gets to beyond a certain set point, the autophagic buildup resolves. That's what she has seen in the human samples.
So this really then makes us advocate very, very strongly for newborn screening, because even the data shown by Joan today was very suggestive that with earlier, we see this, but I think the rationale is even more convincing now because of a factor which cannot be reversed then.
That's right, but I think in all fairness, the data are very limited, and we need a lot more experience and information in the human studies to fully resolve this issue.
This may be a similar question to what Dr. Krishnani just asked, but Dr. Rabin, in your beautifully illustrated article in your medical illustrator is to be commended, because those stage 1 through stage 5 diagrams in the article are stunning. Are you intimating that persons with stage 1 and stage 2 muscle changes would be the ones that would respond most likely and most robustly, and therefore identifying those patients at stage 1 and stage 2 would be a primary goal of treatment?
Yes, certainly. The only thing is that I do not accept those changes which were described, which were recently described in the paper. So as I said, I think that there is no global expansion of the lysosome in muscle fibers, but I absolutely agree with you that the earlier stage, and it may well be that even at this stage, I've done my studies in Pompe mice at a certain age. It may well be that if you really start, my earliest stage was 1.5 months. I see the autophagy, the increase in autophagy in 1 month old, but I never started at 3-week-old or at 2-week-old. It may well be that it would be a spectacular effect. So I think that this raises the question whether it makes sense to start therapy in asymptomatic patients. So that's basically where the question is.
I think that's a critical issue if you think of identifying persons in the newborn screening program who do not have at that time observable disease, such as weakness and heart disease, whether or not it would be essential to start the treatment before there's any symptoms to prevent the autophagy, and that obviously is a rather imponderable question that will need to be considered at great length. Are there other questions and so forth? Let me ask one question. This week's Nature has an absolutely beautiful article from Italy where investigators treated the Duchenne muscular dystrophy dog with stem cells. And I'm not sure how many of you have seen that, but the dog responded quite dramatically, and they demonstrated the production of dystrophin, etc. I raised the question to ask our colleagues from Genzyme, are you considering, we've talked about a couple of kinds of therapy, but one subject that did not come up are stem cells, and are you thinking about that, and do they have a role? You're a private organization, so you can work on stem cells.
No. We do have a stem cell program with Genzyme, but again, I would characterize this as yet another emerging technology that we will look at. But I would characterize it as perhaps half a step behind where gene therapy is. I think where the whole stem cell field is really growing, and I think where it is maturing rapidly, but it's still somewhat behind where I would classify where gene therapy stands today. So there are issues that obviously can be translated to the studies that we reported in Nature, as you indicated, but it's the practicalities that are still issues. So, where do we find these stem cells? How do we isolate them? And how best to deliver these to the right sites are still issues that would need to be addressed.
Question for Nina. Re-asking what I asked yesterday on glycogen storage and how it affects muscles. Is it in fact, am I understanding properly that in muscle mass there will be some muscle that will be normal, that's not affected by storage, as well as those that are affected by various levels? And myozyme, if it removes the glycogen from the affected muscle, does it improve the response of good muscle, or am I just misunderstanding?
Does it respond? Could you please repeat the last part of your question? If the myozyme, the last part, please.
Yeah, if the glycogen is removed from affected muscle, does it improve surrounding muscle that's less affected?
I don't think so, because if you have there is certainly a tremendous heterogeneity, at least from what I see in adult patients, in late onset, tremendous heterogeneity among the fibers, and even heterogeneity within the same muscle fibers. So part of it may be severely affected, the other part may be very mildly affected. And by the way, that is why the regular muscle biopsy can be very misleading, because it depends where you cut. So you can have a very false impression about what is going on. If the glycogen is successfully removed from the affected fiber, I don't see how it can influence the neighboring fiber, but maybe the Genzyme people will have a better idea.
Would agree. So then it really has to do then with getting it removed before the muscle has been severely damaged.
Yeah, and the question is, so we're always saying early intervention. What is it, early intervention? Really before the symptoms occur? And that's one of the questions. The question is, what causes the symptoms to appear? Is it really the expansion of lysosomes? And apparently it happens right from birth in late onset patients. And so it takes years and years, if not the decades, to accumulate and to expand. And nothing happens. The patient heals quite well. So what is the pathological cause of the symptoms? And that's a question which needs to be addressed. In my point of view is that autophagy, if not the only, but plays a very significant role in the beginning of the disease in terms of the symptoms. But there may be something else, and it needs to be looked at.
It is very clear in other neuromuscular diseases that you have to have substantial damage ordinarily before you develop symptoms. And so it will be essential to develop some technology that would identify the time at which treatment should begin. Because if you have symptoms, you probably have already lost some muscle mass that will be very difficult to regenerate. And that will be a very important scientific program to look at. Are there other?
One final one for Nina. Then from your mice models, Nina, the best response you've seen from treatment is diaphragm. Is that a true statement?
Yeah. The best response we have seen is extremely high dosages, 100 mg per kilogram, kind of as a proof of principle. Heart, no problem with minimal dosage. Diaphragm, no problem with minimal dosage. Skeletal muscle, not clear glycogen completely, even though there's extremely high dosage.
Thank you.
And we have a question here. Yeah.
Right.
I'm interested in the calf muscles in terms of the accumulation of glycogen there, and so I've watched a number of kids in the trial that were higher functioning kids that were walking around have kind of a progressive increase in the size and the feel in terms of their calf muscles, and how that kind of plays out in terms of the potential type 1 versus type 2. Because we know that the gastrocnemius, which is really important muscle in walking, is that two-joint muscle there, and it is a type 2 in comparison to the soleus, which is just the type 1 muscle. So I know that I'm just interested in the conversation about what people think is going on there.
Any comments about that?
I don't want to comment about humans, so I would like Priya or Hans to comment about this in humans.
Priya, Hans, do you have a comment? Yeah. Priya does have a comment, if we could bring it up. And then after Priya, our colleague here in the white jacket.
The only comment what I would like to make is in the early stages, or actually before the start of therapy, it's a very interesting phenomena that although there's low muscle, low tone or inability to move, there's this involvement of the gastrocnemius, I guess because of glycogen accumulation, and a very firm feel to the muscles, which in fact really helps clinically make the diagnosis. What we have seen is that in the majority of patients, there is actually a resolution of this over the course of time with therapy. But in a subset of patients, actually, there's a resolution and then sometimes a reoccurrence of it, almost like a pseudo-hypertrophy of muscles. And I think that would be interesting to study further. Are those the patients who have more of, say, type 2 fibers or a lesser response over the course of time? And thus, I feel the value of long-term follow-up of these patients is essential. Are these the patients who are losing more ground as compared to the others?
I just have a very short comment on that. And again, it's not in humans, it's in mice. But the hypertrophy you see in type 1 muscles, which really have expanded lysosomes and much more glycogen accumulation. In type 2 fibers, once you have this autophagic buildup, it's always a profound atrophy. So the suggestion from this, what you're saying, the enlargement of the calf muscle would be whatever the fiber type is, and we shouldn't be fixing on that. So this is less important. So it's much more important than rather than naming them type 1 and type 2 to see what's going on. It's quite possible that those fibers where indeed the glycogen accumulation and expansion of lysosomes really occurs.
I think my question would be for Dr. Chang. I was wondering if there is any data on the mice that you have that are treated after a year. Any data, what happens if treatment is stopped and then say 6 months to a year after that, do they maintain those gains or do they deteriorate again?
That's a great question. We haven't tested that concept, but it's something that we want to test actually. But my prediction would be that it will build up again. And based on the experience in other lysosomal storage disease in patients, when we've actually withdrawn treatment or patients have chosen to withdraw treatment, the disease rebounded rather quickly. And it was actually quite hard to then reverse that again. But we want to test it in the context of the Pompe mice, and hopefully we'll share it with you the next time.
I don't really know which panel member this goes to. Whenever you get into the myozymes of the mice, did any of them have an adverse reaction to the medication going into them? The reason I asked is my wife had the myozymes or the clinical trials that they had bringing a crash team for her. And I wondered if any of the mice showed any adverse effects to the myozyme coming in there.
Yeah, the mice, they do have an adverse effect at times to the myozyme because we're giving a human protein to a mouse. And so they develop an antibody response. So it makes it difficult for us to do repeat dosing in mice without having to give them an antihistamine to control that antibody, that response, that histamine response.
But when the myozyme is given to mice which are tolerized, they tolerate it quite well.
I just had a quick question regarding nerve cells. Has anybody looked at infiltration to nerve cells as far as them being having a problem in nerve cells and then correcting any kind of glycogen storage or autophagic buildup in the nerve cells? Even if you sort of ignored the muscle or if you completely cleared the muscle of any glycogen or autophagic buildup, would you still have a neurological issue? And can you resolve it?
So the only sections that we've actually looked at is the dorsal root ganglion, and there is storage pathology there, and we can clear it with enzyme replacement therapy.
With ERT?
Yes.
Oh, with the neo-ERT?
Oh, with both.
Good, okay. So it's able to cross the blood-brain barrier?
Well, the dorsal root ganglion is somewhat forced, so it's not on the central level. It doesn't cross into the CNS, but the dorsal root ganglion is somewhat permeable.
Okay, thank you.
I just had a quick question. I'm wondering if the neo-GAA, if that, it seems that the liver sync is a real problem. Are you seeing improvement with the liver sync problem with the neo-GAA?
No.
No.
We're just getting, we did develop an entity that has a very much higher affinity for the receptor. So the few times that it is seen by the receptors in the muscle has a better chance of being attached and being internalized. That's the concept I think we're working on. But it doesn't take out the sink in the liver.
Although it's very difficult to prove directly, at least what we would infer that it must, since myocytes are clearing of accumulated glycogen, the inference is it must be getting to the myocytes. And so the way it's doing that is somehow bypassing the lysosomes of the endothelial cells, for example.
I guess my question is how, I tend to think in black and white, but I guess how efficient is the process, I guess? I mean, obviously some must be going to the lysosome, but some is bypassing the lysosome. How much do you suspect is going through the lysosome? And if it gets to the lysosome, is there a chance that it could come out the other side into the muscle interstitial space? And in that case, it wouldn't be affected, but it would still be there.
I think that there's of course, there's a chance that some could get back out into the interstitial space, but I think its ability to be retaken up would be very diminished.
Right. That's why I'm wondering if the chemical conjugation could improve that problem, if that were the case, because you have a random distribution of the mannose-6-phosphate, and even if it does get cleaved in the lysosome, it still may you still may have some residual effect, and it may still bind to the receptor on the muscle cell. Just
it's an interesting hypothesis, and it has yet to be explored.
I think that the truth is that we don't really understand that process, and there's great PhD students.
It looks like the questions, are there some final questions here? Rochelle has a final question. She started us off, and here comes the microphone. Hold on.
This is a question. Has anyone looked at bronchial endothelial cells? Because you wonder that if there's storage in bronchial endothelial cells, those cells play a tremendously significant role in respiration.
It looks like we can get some endothelial cells here from Rochelle. The answer apparently no one's looked. So forth, but just thinking about it gives you choking spells. Are there any final comments? Let me thank the panelists. It's been an extraordinary group of presentations, and the questions have been wonderful, and I think more importantly we're on time, and now I think that the program goes over to Mr. House for closing remarks. Is that correct?